What has a lifetime of experience taught me about trying to go ahead and work with our first responders and answering one of the fundamental questions that is the most difficult to answer, and it's one of the elephants in the room. Why do our people hurt themselves? Why do they take their own lives? Okay. So, as I study this, I break it down into a three-part problem, all parts psychological. If you want to really understand what's going on with first responder behavioral health and why there are issues, you have to look at it from the psychology of the self, the psychology of the service we provide to the public, and then the psychology of the system or the organizational development piece. And sometimes that's the biggest challenge. Let's look at psychology of the self for a moment. When I ask my first responders, can you define a healthy lifestyle? Most of them are unable to do that for me, and most of them are eating fast food when I ask this question at the station. Now, nurses don't score much better, and they at least had a nutrition class. So are you able to define a healthy lifestyle? What does that look like for you? Also, another part of the psychology of the self is emotional intelligence. Are you self-reflective? Do you take criticism well? Are you capable of sitting with an issue and boiling down your part in it, which actually becomes problematic as people slip into post-traumatic stress? That aspect of logic and reasoning tends to go. So do you meditate? Do you exercise? We have evidence-based, empirical-based studies that prove that diet and exercise is equal to most mild and moderate antidepressants. Yet most people, even medical professionals, will go on out and get the pill before they'll go on out and take a walk, take a run, take a swim, look at their diet. And that is a problem that is with us. So what does your own health look like, your wellness? What are your daily practices? What are you doing for you? Self-care is not only not selfish, self-care is essential if you want to go ahead and stay in this job, in this profession for the long term. What is your outlook on the future? Do you have a future orientation? It's another question about self. What are ACEs? And what I mean by that is a term that psychology has come up with in the last few years. It stands for adverse childhood experiences. So, said differently, what did you bring to the table on the way in? Was there a troubled childhood? Difficulty in the youth? Did you do 2 or 3 tours in a combat zone before you became a paramedic or a police officer? So were there some adverse childhood or adverse experiences that you brought with you that haven't been resolved yet? And if that's the case, that's going to lower your resilience and give you not enough resources to maybe get through some of those crises. And also, what do your current relationships look like? So the psychology of the self. The next aspect of this is the psychology of the services we provide to the public. And there's a big issue there. The first issue is this: how do we provide behavioral health services to the public when it's simply not included in our training? I have amassed in my career probably every paramedic manual and EMT manual ever written, and I've gone through all of them on this subject. Most of our training has 10 to 15 pages in those manuals, and a really good one has almost 30. Half of the information in those pages is about taking the subject down without hurting them or yourself and protecting yourself. It's not a whole lot of de-escalation training, not a whole lot of psychology training, no behavioral health training. It's about staying safe, taking them down, and then deciding what to do with them afterwards. So we simply don't have the training, and the reality of it is that we find in the modern fire service today, 80% of those calls are medical, 20% are fire. Of the 80% that are medical, 40% of those calls are behavioral health based. And many times we don't even score that correctly. We'll get to that traffic accident, we're treating a trauma, we have a car on its side, yeah, the guy is drunk, and we move on to the trauma because that's what we've been trained to do. In reality, That's a substance abuse case that spun out of control. Yes, it's trauma too, but we have a behavioral emergency. What led him to drinking so much? Why are we here at the scene of an accident? What pain was that individual trying to avoid and suppress with drugs or alcohol to the point that they hit another vehicle? And that's part of the behavioral aspects of it, and we tend not to score those calls that way. So, do you have protocols in your system as well, talking about the service, that allows you to deal with behavioral health emergencies? I did have the extreme privilege, as Juan mentioned, to visit with the medical directors in the state of Texas, and not a one of them believed that we should be bringing these patients to the hospital and handcuffing them to a gurney for 12 to 16 hours because we don't have any services to provide there. Unless there's, they need to be stitched up because there was a suicide attempt and we have to go ahead and seal up a wound. Unless that's the case, that there's some other medical concern, then all we have is an individual waiting for a bed at a mental health facility. Well, what about protocols that will allow you to divert that call directly to the mental health facility? What about protocols that would allow you to go ahead and release that individual to a relative so they can be transported to their counselor's office and maybe de-escalate and close out that call after the paramedics have done their assessment, of course, and deem that they're within a certain parameters and protocols that they might be able to be diverted into another method. Also, we are starting to see a reflection of this in the community paramedic program and programs that are starting to emerge all over the country where we're looking for different alternatives. So community paramedicine starts to address this. Some agencies are starting programs where they have a police officer, a firefighter, and a social worker in the vehicle, an unmarked vehicle, and they'll attempt to de-escalate the call that way. Lubbock Police Department has one of the most amazing programs with 40 therapists in their system. And most nights, there's 2 of them sitting in a car, and they dispatch behind these behavioral health calls, and they'll try to provide on-scene counseling services and support right there. That is a major paradigm shift and a major game changer, and I believe Houston as well is a similar program. But the problem we're facing is these programs are all too few. So the psychology of the services we provide and how we can potentially provide them better, that's one of the issues. The next area that we have to examine is perhaps the toughest area of all. The psychology of the system, organizational development, leadership development. Or said differently, do you work in an old school or a new school system? Do you have inspired leaders who are into leadership and taking everyone to the next level? Or do you work in a fiefdom, a top-down system with toxicity as a general aspect of the organization? Are you valued in this organization? Is your voice heard when you bring up questions, problems, and concerns? Or are you shunned for going ahead and trying to improve the place? So many agencies really embrace leadership development. Other agencies, not so much. And that's where we see the problem. When we look at the elephant in the room, what do we do to make the system better? One of the elephants in the room happens to be our leadership and its role in first responder suicide. So why do first responders take their own life? That is the real question I'm trying to get to the bottom of. Why would somebody that stepped into a healing profession and wanted to go ahead and save and preserve life take their own? What's going on there? So I've dedicated a large part of my life to studying this, largely because I was standing in the middle of an epidemic I didn't realize I was in the middle of. When you're working and you've put in, as I have, about 35 years, you are losing 2 to 3 people a year. So 35 years later, I'm sitting there looking at having lost more colleagues to suicide than are often in my lectures. And that's in a room of 100, 150 people when I speak. So that is an epidemic in all measure. The problem is we have trouble measuring it. So Police officers, we know this thanks to the work of Jeff Dill over at the Firefighter Behavioral Health Alliance. Police officers and firefighters are more likely to die by suicide than on the line of duty. Or said differently, we are more dangerous to ourselves than any burning building you're going to walk into or any bad guy you're going to try to take down. The real danger is us, because we're not taking care of ourselves. So Firefighter Behavioral Health Alliance estimates that approximately 40% of the firefighter suicides are reported. This is the information and statistics I have to bring to you today, and over 60% of these incidents are not being reported. When Jeff Dill speaks, he'll often talk about the fact that they're not cooperating or stonewalling him when he tries to go ahead and do the after suicide follow-up and get information and data. How can we, as a profession, treat an epidemic without accurate data? The one thing we know for certain is this: the problem is far worse than our statistics indicate. Many of the times we don't want to talk about it. The family doesn't want that out there. Don't tell reporting agencies like this the truth. Look, by the way, Jeff Dill is a retired firefighter paramedic, and I believe he's a licensed therapist, I think in Nevada. When agencies like his call out, very much, verify who they are, of course. But if this is a legitimate agency doing legitimate statistical research work for us, please get somebody to call them back and give them the data that they need so that we can get better numbers and be more accurate.